Well, thank you so much for that kind introduction. It's really nice to be here and have a chance to talk to all of you today. I'm going to take us on a little journey to the other end of the GI tract because I'm going to be talking about endoscopic management of colorectal anastomotic leaks. My only disclosure is that I'm the co-principal investigator on a research grant from Intuitive, but this really is going to have no impact on the content of my talk today. Objectives of this talk are to review with all of you the indications for trying to use endoscopically salvage a colorectal anastomosis that has leaked, and then discuss some of the endoscopic tools that are available and are feasible for this particularly vexing problem. There we go. Now, I'm sure it hasn't happened to any of all of you out in the crowd, but on occasion, despite our best efforts, colorectal anastomoses can have a little bit of trouble healing. The most commonly quoted rates for colorectal anastomotic leak range from about 5 to 15%, with some variability based on the exact definition of what is going to constitute a leak. Risk factors for leak include a low pelvic anastomosis, prior radiation, poor nutrition, ischemia, steroid use, obesity, male gender, and advanced age, among other factors. Consequences of these leaks can range from mortality, as well as serious morbidity, and development of additional complications such as fistulas, chronic sinuses, anastomotic strictures, and compromised bowel function afterwards for patients. There's a variety of management strategies for leaks. Sometimes it's necessary to just take them back to the operating room for a washout, for resection, revision of the anastomosis, drain placement, and then ostomy creation if there hasn't been an ostomy already. Unfortunately, if a colostomy is created, especially in these situations, there's a pretty good likelihood that it's going to end up becoming a permanent colostomy. Somewhere in the range of only 50% or less of ostomies are sometimes reversed after situations such as this. In other instances, we can use percutaneous or even transanal drainage in these pelvic abscesses, antibiotic treatment, and nutritional support. Increasingly, however, there seems to be a role for endoscopic tools that can be used to manage these anastomotic leaks as well. Now, there's definitely situations where it's not safe or feasible to try to pursue endoscopic management. Obviously, patients with diffuse peritonitis or signs of end organ hypoperfusion from their leaks belong in the operating room. Likewise, in the setting of bowel ischemia or frank necrosis, endoscopy is really not going to be appropriate. So I don't think I'm going to be talking about anything that we haven't already heard about from other panelists, but one of the first interventions that I'll be talking about is colonic stents. So in my world, originally self-expandable metal stents were used for near obstructing colorectal malignancies, but their use has been extended to other indications, such as anastomotic strictures, fistula formations, or leaks. There's fully covered, partially covered, uncovered, or even some people talk about biodegradable stents that are available for use. A lot of the series that are looking at colorectal anastomotic leaks have used partially or fully covered stents. All right. So we all kind of know how these work. You place the stent across the area of concern. In this case, your anastomosis that has the leak associated with it, using a wire. Expand the stent, typically using a balloon, and then make sure that you're in good position by checking with fluoroscopy afterwards. So the data on stenting in this particular indication comes primarily from retrospective series. There's a nice systematic review of colon stents that were placed for a variety of colorectal anastomotic complications, including leaks, but not just leaks. This review actually included 223 patients that were gleaned from 32 studies. They found resolution of leak to be 74.5% with a complication rate of 32%. And they really didn't define what exactly those complications were. However, in about 9% of these patients, surgery was required to fix that complication, so I think we can guess what that is. The mean time to being able to remove the stents was just over 61 days. And considerations that are specific to stents and have been talked about before are the rate of stent migration, which in this systematic review is over 40%. as well as sometimes it's just not possible to place a stent over a colorectal anastomosis, and this can lead to the need for surgery or other interventions. As we talked about, stent migration is a problem, particularly in situations like this where there's not a stricture or a mass to hold the stent in place. Various authors have reported using through-the-scope clips to anchor the clips in place. Some have described fibrin glue or other ways to try to keep the stent in place while waiting for the leak to heal. Another endoscopic tool is the over-the-scope clip, or sometimes called the bear claw clip because it kind of looks like a bear trap. They can be used to close these defects. You can try to use through-the-scope clips sometimes to close very small defects, but a lot of times the through-the-scope clips are of limited utility in colorectal anastomotic leaks because there's fibrosis or inflammation. They can't generate enough force to kind of bring the edges of the tissue together, or they have a small size. There's a role for them, but they aren't always as efficacious as we would want. I'm not going to go through the details of using it because other people have, and this is familiar with us, but basically the key maneuver, just like with upper endoscopic use of this, is to draw the tissue up into the scope and be able to place the clip, occluding the area of leaking. Like I said, those are some of the commercially available devices that can be used when placing these clips. So, when the edges of the, so the data for the interventions is again primarily from retrospective cohort studies and case series. And a lot of these studies have kind of a mixture of indications for clip usage, including bleeding, acute iatrogenic perforation, as well as colorectal anastomotic leaks. There is, again, another very nice systematic review by Clifford et al. That reviews a variety of endoscopic interventions, including clip placement. The studies are a little bit hard to interpret because of the mixture of indications and the heterogeneous outcomes that are reported. But resolution of the leak is confirmed by either a contrast enema or endoscopic evaluation at the time of clip placement in these studies ranges from 65 to 86%. In patients where the clip was not able to be placed, oftentimes they were able to have other endoscopic interventions or did end up requiring revisional surgery. Long-term outcomes are somewhat sparsely reported for this indication. And again, because of the size of the clip, as was mentioned previously, there is some limitation on the size of the defect where things larger than 2 or 3 centimeters are not necessarily appropriate. It also seems that this is successful in more of an acute setting, but is certainly worth using in a more chronic setting. For the colorectal literature, the definition of what is an acute versus a chronic anastomotic leak is somewhat variable. It's not really standardized, but it makes sense that you're going to need to think about it differently and use different tools if you have a more chronic, acutely inflamed anastomotic leak versus, a more acutely inflamed anastomotic leak versus a chronic fibrotic scarred down sinus or leak. The third endoscopic intervention I'm going to be talking about is the endoluminal vacuum therapy. Just like you can use it on the upper end of the GI tract, you can also use it on the lower end of the GI tract. Using the exact same principles of negative wound pressure therapy, but can be applied transluminally. So using the colonoscope, you can check the size of your abscess cavity and then use that to assess what is going to be the best tool for treating this. So there are commercially available systems that are designed for this that already have the tube in place and are pre-attached to a negative pressure bottle with devices to help you place it. Or you can make your own, as has been discussed, just like was discussed for fashioning a custom-made sponge using one of the commercially available multi-purpose negative pressure wound therapy systems. This can also be used to manage abscesses and fistulas associated with a colorectal anastomotic leak. The tube then exits transanally, so at least we don't have to worry about people getting confused that the nasogastric tube is a nasogastric tube. And then this can be attached to the suction device. It does need to be changed about every 3 days or so, and this typically does require return to the endoscopy suite, which can make the logistics of this treatment a little bit cumbersome, especially if the patient is otherwise appropriate for outpatient management, which sometimes they are. Outcomes of this therapy are, again, primarily reported in case series and cohort studies, and the same systematic review that I was talking about before also looks at use of endoluminal vacuum therapy. The anastomotic salvage rates were about 89%, and they ranged from 66 to 100%. There are some adverse outcomes that are associated with this particular treatment modality. They don't happen often, but they're pretty memorable, and they can include reports of erosion into significant vessels, leading to bleeding, and then formation of fistulas to surrounding structures, such as the ureter, the small bowel, or the vagina. The median number of days in this particular systematic review of therapy was 22, with a range of 2 to 109 days. And it should be pointed out that 2 days was the case where there was significant bleeding associated with the sponge, and so they stopped using that therapy. The mean number of sponge changes required for this modality was 7, again with a wide range. It seems in some studies that this works a little bit better when used earlier in a leak, with one study reporting that they had a success rate of 75% if the endoluminal vacuum therapy was used within 6 weeks postoperatively versus only 38% if it was greater than 6 weeks. At a certain point, the cavity is going to get pretty small, and it can be difficult to place a sponge, and some authors have reported at this point switching to treatment with fibrin glue in order to occlude the remaining cavity that's left. Also, while diverting stomas are oftentimes in place when people have these leaks, they're not strictly necessary to consider this management strategy. There's one study that reported that only 82% of their patients were diverted at the time of using endoluminal vacuum therapy. Interesting to know, but it does sound kind of messy. So colonic stent placement, over-the-scope clip placement, and endoluminal negative pressure therapy are 3 strategies with described track records to suggest them as appropriate tools in well-selected patients. There's a number of other tools that have also been described in previous talks and otherwise for this specific situation. So endoluminal pigtail drainage catheters can be placed in colorectal anastomotic leaks as well to gain control of a cavity without having to use potentially a percutaneous drain, putting people at risk for colocutaneous fistula formation. Fibrin glue has been described. The success rates are about 16% when used for colorectal anastomoses, but it is a tool. Some groups have described using the endoluminal sponge system to actually instill topical medications into the abscess cavity to assist with wound healing. And then in certain situations, particularly very low anastomoses where you wouldn't necessarily want to place a clip or a stent because it would be in an area of sensation, when one develops kind of a chronic fistula or sinus tract, it actually can be possible to unroof that sinus tract. This has been particularly described in ilioanal pouch anastomoses after total proctocolectomies. One can use a needle knife or a stapling device or a bipolar vessel sealing device to actually do almost a tractotomy or unroof it and make that cavity part of your pouch. And then in some situations, again, depending on the exact location and how high or low your anastomosis is, it's possible to use some transanal surgical platforms or endoscopic suturing devices, as are shown here. People have been using TAMIS platforms and things like that in order to try to repair leaks as well. So to summarize, endoscopic management of colorectal anastomotic leaks can be used in patients that don't have a hard indication for return to the operating room. Techniques such as stenting, over-the-scope clipping, negative pressure wound therapy have relatively high rates of anastomotic salvage, around 70 to 80% in most series, with low complication rates. There's ongoing innovation that's continuing to take place, both in the setting of different surgical tools that are available to find better and easier strategies to deal with this particular complication. So thank you again so much for your attention, and I'd be happy to take any questions that you might have.